Hi, he is a 65-year-old gentleman who has pseudoexfoliation and an immature cataract. Nuclear sclerosis is around grade 2 and he is posted for surgery. The pupil is moderately dilating, and because of pseudoexfoliation, we expect some loose zonules as well. Preoperatively, the intraocular pressure is around 20s in both the eyes. The antechamber is relatively shallow. So I'm using an indirect surgical gonio lens to demonstrate the angle status here. You can see that none of the angle structures are seen in this quadrant. Same here. And in this quadrant, we are seeing this wavy pigmented line, which is much more anterior than the Schwalbe's line. This is not to be mistaken with Schwalbe's as a trabecular meshwork, but this is a Sampolesi's line. And in this quadrant, the pigmented trabecular meshwork is just faintly visualized. So in most of the angle structures, the pigmented trabecular meshwork is not seen. Let's see how the angle changes after the lens extraction. The incisions are created. The eye is filled with viscoelastic. And expecting an intraoperative meiosis or to deal with any intraoperative surprises, I'm going to use a pupil expansion device that's a B-hex ring for just to be on the safer side. The globe is stabilized and the first pair of notches is engaged into the pupillary margin, followed by second pair. The hands are switched. The final pair of the notches are engaging onto the pupillary margin. The pupil is now decently sized and I don't have to bother about any intraoperative meiosis. As I'm puncturing the anterocapsule, there's just a little hint of folds on the anterocapsule, suggesting that there is no major zonular weakness, and the rhexis could be completed quite easily. It's about 5.5 millimeter. Time to perform the hydrodissection. The nucleus rotation is confirmed. And now is the time to emulsify the nucleus. Because this nucleus is relatively soft, the parameters are going to be significantly lesser. For chop setting, I'm going to use a power of 10% longitudinal. Just support the nucleus with the phaco tip using very little energy, and then the vertical chop is done. The nucleus is rotated and the nucleus is now being divided gently into smaller fragments. The nucleus is very soft. It's not a big issue to deal with this nucleus. The only critical factor is to use the right amount of phaco energy. So lower the better, and using a longitudinal energy ensures that we get at least some grip to hold and then do the vertical chopping. Now is the time to emulsify each of these fragments, and it's done quite easily and quickly. Now is the time to aspirate the cortex. So the bimanual I&A is used to aspirate all the cortex. Now I just want to pause here and just show you the fine fibrils which are there on the posterior capsule. And just I would want to spend a few seconds here using BSS to just blow them away. So I'm going to push BSS across the posterior capsule. This ensures that the posterior capsule is cleaned off, and this is one of the easiest ways to clean the posterior capsule. Only care is to be taken that the cannula need not be very close to the posterior capsule. Gentle irrigation of BSS across the posterior capsule usually clears off all the small fibrils which are sticking onto the posterior capsule. The OVD is injected into the bag and the originally planned lens is dialed into the bag. Now is the time to go back and assess the angles. So I'm going to go in the same order which I had shown preoperatively. And you can see in this quadrant, the thick pigmented trabecular meshwork is very easily seen now. And similarly, in all the other quadrants, the angle opening is dramatic. So let us look at these pictures before and after lens extraction combined together. So in all these pictures, it's very clearly seen that the angle opening is quite dramatic once the natural lens is removed. A cause for concern in this patient would be the amount of pigmentation. The entire angle seems to be very densely pigmented, and as is to be expected in an eye with pseudoexfoliation. And in these eyes with densely pigmented angles, the risk of intraocular pressure raising subsequently would be quite high, and my advice to my patient would be to have a lifelong follow-up and always get the intraocular pressures checked quite frequently. The BHEX ring is removed. The OVD both in front and back of the lens is aspirated out. And the spots are hydrated. That's it, the case is done. So these are the post-op pictures and the patient is doing fine. The intraocular pressures on the first day were 18 and that's it. Thank you for watching.